So Kevin already introduced our Oncovalue consortium, and I just remind that all our 5 clinical centers are OSEI centers, cancer centers. And today I will tell you how to organize and maintain data collection as part of standard clinical routines. Because we all know that we get all the time the data. So there will not be the day when we should collect that afterwards, only in an old-fashioned way. So we have to get it automatically as part of our standard clinical routines. And Kevin already told about that it is equally important then later on to harmonize the data to be able to do the federated analytics. So the tools within Oncovalue consortium, as in other EU projects, are the use cases. And our use case for HUS is the work package 1, where the aim is to be able to collect real-world data as fully structured data. But already as this phase of my presentation, I can tell you that we are also prepared for the hybrid possibility. So we are developing also Finnish language models for text analytics. And we are also developing tools in collaboration with Siemens to be able to get automated analytics of whole body CT scans. So our use cases are in breast cancer, and the first case was is in early breast cancer, because it's easier to learn to do this in the beginning of the patient path, because the data is more simple in the beginning of the path than during the following path. And we chose as the use case pembrolizumab in the adjuvant treatment of early breast cancer. And pembrolizumab received the indication from EMA in April 22. And in Finland, we have a system that if an earlier drug receives a new indication, it is evaluated first at one university hospital, and if that accepts it, the rest of the university hospitals and other public hospitals then take the drug in use. And that happened then in December 22. And so first of all, of course, it was important to dig into the data behind the indication. So there have been 2 publications in New England Journal of Medicine, first one in 2020 and the second one in 22. And the overall survival outcome results have not yet been published, but I've heard that they will be published in the autumn. And sorry for this, this is a little bit unclear. I don't know if you can do anything for that. So, sorry. So within our consortium, we decided to use the table 1 of the publications as a starter. So we digged into according about this study. So we went through which are the relative patient characteristics. So, of course, age, menopausal status, and the ECOG performance status. So, our analysts, Juho Lähteenmaa and Joonas Laitinen, so they were digging in the HUS data lake around this data. And here you can see the results at HUS. So in our patient group, this includes all patients, So the median age was a little bit higher than in the publication. And well, the menopausal status was almost the same. But here you can see that the ECOG status there in the bottom was pending in 60% of the patients. So this is the take-home message that your data is not what you think it could be. So here is something to implement to motivate clinicians and nurses to also document the ECOG status, because we know it all the time. About our use case, so we are not trying to repeat the study. So we don't have the same inclusion criteria as in the study. We want to, of course, characterize the patient group, but the idea is to have a look to get the efficacy or effectiveness of this new drug in our patients. And of course, the numbers are very small, but this is about the federated data analytics, since all the hospitals have to do their own data collection and harmonization. Without that, we cannot combine the data and do the analysis with numbers that are big enough for conclusions. And then we move to the tumor characteristics. And in the publication, you can see that the PD-L1 status, it was inclusion criteria to assess it, but it didn't have an impact in the outcome. So the drug received the indication without any preceding PD-L1 diagnostics. So we don't have it because we don't do it because it's not needed. And about the primary tumor nodal involvement and HER2 status, so here are our results, and as a matter of fact, we had a little bit smaller tumors. So we had T1 to T2 tumors in 83% of the cases, and in the publication it was 74%. So there was at least the numbers are a little bit higher in our patient population. But the nodal involvement and the HER2 status score, they were very similar. And about the safety. So first of all, we didn't have any toxic deaths. But when it comes to the adverse events, that is something to be done. So that is the part of data which we do not have it structured. But our plan is now we use EPIC as our medical health record, and we are going to get the finished version of the MyChart of EPIC that collects the adverse events from the patients digitally. So they are graded already in the app as CTC AE grading for patient-reported adverse events. So that is our future plan. But for now, we only could get the patients, we could identify the patients who stopped the Pembro because of adverse events. And here you can see that almost a quarter of the patients interrupted the treatment before the planned cycles due to specific immuno-oncological adverse events. And then in addition to that, one patient had neutropenic sepsis that led to the discontinuation of the treatment, and one patient had renal failure. And nowadays, so at our hospital, so we have collected the quality of life outside clinical trials as clinical routines 1.5 years. And here you can see that only 12 patients had responded to the digital questionnaire at baseline and at 6 months. So here is also something to improve in the future if we want to include quality of life in the analytics. It was not reported in the publication, But so I think that as part of clinical routines, it would be excellent if we all could get the quality of life. So if we combine the quality of life with the ECOG status, we have quite a lot information about how the patient is doing. Then the second publication, so that was about the event-free survival. And in this paper, so at 3 years, 85% of the patients were disease-free compared to the comparator arm of 77%. And here on the right side, you can see that, as a matter of fact, the patients who had smaller tumors benefited more. Probably that was not a surprise. And then here you can see also that the PD-L1 status didn't make a difference. So about the event-free survival, so this follow-up is quite short. The median time in our material was 13.1 months. And during that follow-up, 90% of the patients, they were disease-free or event-free, meaning that they didn't have any disease recurrence and they were alive. And similarly, the overall survival was 93%. So in the future, the plan is, with longer follow-ups, probably to do that kind of assessment once a year or once 6 months. About the technical solutions, so our analysts, Juho and Jonas, they had the system, the data extraction system that they themselves, as pioneers, built in the HUS data lake regarding this patient group. And so our clinicians, and we have a PhD student, Meri Maunu, was supporting them. So if they needed, if something needed to be checked or validated, so they did that. And so the main data sources were, of course, the EPIC electronic medical record, and then, of course, our pathology reports are in the MyPlus system, and then the lab values in the multi-labs system. So in the future, I think that when we take novel drugs in use, so of course we need to know the effectiveness and the cost effectiveness of the treatments, but as important as that is to be able to identify the best and worst responders for the therapy, especially the worst responders, because they do not benefit from the treatment and they need something else. And because of that, because we need to characterize both the patients and the tumors, so at the same time as we started the Oncovalue project, we also implemented a systematic collection of biobanking consents of all new breast cancer patients in the beginning of their patient path. And in the future, we will continue to characterize also the tumors. And once we are a little bit longer, we will then move on to the following use cases within Oncovalue. And I can tell you that other tumor type multidisciplinary groups are already eagerly waiting for their moment to start this, and the next tumor types will be colorectal and melanoma in the row. So I think that this first case, it's always the most troublesome, the slowest, and once you get it up and running and you have done all the quality assurance, what Kevin just told, then it's time to move to the following tumor types, and that goes, my guess is that that will go more easily and rapidly. So thank you once more for the whole Oncovalue consortium.
So maybe as a first question, what did you learn from this from a clinical point of view?
So from the clinical point of view, when I go home on Monday or to work, so I will go and discuss with our clinicians that we need to put on the echo. I know that at some centers, the nurses put in the echo before every infusion. So this is something we really need that because it's our duty to check that it's good enough.
Yeah. Okay, there's one question over there.
Hi, thank you for your presentation, Johanna. Sometimes in real life, we offer the drug for patients that would not be eligible to the trial because of some comorbidity or some other situation. Did you find those patients in your center? And did you include them in your study or you exclude them from the database?
We didn't exclude anything, so this is real-world data. So what our clinicians decided that the patients are fit enough for this kind of treatment. So those patients were treated. So it is in our guidelines that triple-negative breast cancer, pembrolizumab is included in the neoadjuvant treatment. So if the patient was fit enough for the chemo, pembro was also started unless the clinician, we all know that immuno-oncological drugs have certain contraindications, but unless they didn't find any of those, so it was the clinician's decision.
And to add, working with real value, of course, gives the opportunity to compare eligible with non-eligible patients, which sometimes even have comparable results, at least in studies in the NKI. And what also our experience is, for instance, in performance status registration with lung cancer patients, that manually, that is usually retraceable with feedback from physicians, etc., because it is not always clearly noted. But with the language assessment program, only 60% of patients were accessible at the present status. So this structured registration is really an issue for items that we think that are structurally entered.
Now, I'm not sure if I understood your
question.
question.
Well, for lung patients, you have performance status 1, 2, 3, 4. So you think that lung physicians note in the file 1, 3, or 4, but that's not always the case.
Yes, but that is why we need the analysts, and we need to be sure of the quality of the data. Yeah. But I agree, and then one more comment to Victor, that I think that there are two possibilities to compare the results, to follow strictly the inclusion criteria. But this was intentionally done by, if you want to know what happens at your own institute, how the drugs are taken in use and what is the outcome for the patients. So that is why I'm not saying that methodologically it would be the right way to do, but that was our use case.
No, I agree to leave the patients there in the database. It's important to report the percentage of patients that would not be eligible for the trial, the original trial, so we can better interpret the results. If that number is really high, let's say 15, 20%, we are enlarging the population that will be using the drug. So the prices of that drug should go down in the future.
In theory. Yes, in theory, yes. But I think there's an obvious strategy of pharma to enlarge indication ranges. And usually the price doesn't go down. That is a correct issue. Michael.
Yeah, I can only congratulate to the ambition and the belief that you can reliably say something beyond the case study, which I found very impressive. And the reason why I'm asking with a skeptical note here is because anything what you get out of it in terms of reliability is, of course, extremely dependent on the quality of the input data, as you are aware of and as you emphasized. For example, you mentioned cost data. We heard before in the presentation about the problem of capturing prices. From a health economics point of view, we would insist on separating healthcare utilization on the one hand and unit costs on the other hand. Otherwise, you have an immediate issue regarding comparability of the data that you collect. Then you mention you have QALYs as an input. QALYs are a construct that needs to be calculated, and one of the choices that goes into that is, of course, the kind of quality of life measurement that you are going to use. It's a choice of measurement, it's a collecting of the data, and we have seen a lot of missing data actually regarding that. And finally, everything that you do depends, of course, on the diagnosis and the severity for which you need to adjust the data. I have seen in prior analyses that there are, and of course this is not a surprise and this is not really new what I'm saying here, that these data are collected also for administrative purposes, for reimbursement of hospitals. There was once a study in Germany where the claim was made that the introduction of the DRG system led to a huge improvement of the efficiency of the system. Huge amount of econometric analyses and apparatus behind that. But closer analysis revealed it was upcoding that happened, and for that reason it appeared to increase the efficiency, but in reality we had an incentive by the reimbursement system, by the institutional context, to change the coding, and that of course can lead to a lot of interpretations that could be potentially misleading. My question to you is, I don't want to sound negative, but my question really is, how are you managing these things?
So as told earlier, and Kevin presented very nicely, so it's very important to take care of the quality of the data. And that is why I'm very, very happy that we have a WIMS group collaborating. So, and also when it comes to costs, I think it's very, very important. You have to be very precise what kind of data you use. So this was just our first example that what is our view, what we have done in the beginning of the project. But yes, I agree, it's very important to follow the quality of the data.
Okay, I think we thank you very much. And, oh, sorry, a last question then.
Hello, thank you. Thank you for the presentation, and as well as to Kevin. And this question is perhaps more in his field because it's related to AI. Considering that all the data that you are collecting and using AI to collect the data that we are not able to collect, we are gathering substantial amounts of data, providing a holistic overview of the system. In that sense, could we use something called digital twin technology, which is to make replica of what you're producing of that system and to simulate potential outcomes, such as quality, such as health data outcomes? Because if we have all this amount of information, can we use it in this other sense, that we sort of predict what happens if we do this or that?
You want to reflect on that?
If you don't, it was just my reflections, so if you can answer it would be nice, if not, it's fine.
I think that sounds super interesting. I feel like there's a lot to discover still in terms of methodologies for real data. There's a lot of new development, I feel like. Think of, for example, of target trial emulations and these types of novel methodologies that we need to delve into together as well with our research group that have not been implemented too much yet, if I'm correct, as well as the federated analysis, by the way, and even traditional statistical methods that need to be adapted towards federated analytics. So maybe we should start with those as well and then see how far we can get, given those methods, to do these very interesting new applications, as you mentioned, but it seems like a good possibility.
I would presume that using these data for digital twins is only possible if we have sufficient trust in the reliability and all the aspects that were presented. But once that is working, I think that is an interesting venue.